Good evening. So, this series of lectures are in observance of the World Bone and Joint Awareness Week, part of which is the Pediatric Bone and Joint Day, held every October 19th, that seeks to promote children's bone and joint health, as well as increase the awareness on musculoskeletal health issues. And so, in line with this is my lecture on the approach to musculoskeletal problems in children. So musculoskeletal conditions in children are common. The prevalence of MSK pain during childhood has been estimated to be about 25 to 50%. The majority of the cases are benign and self-limiting. So in this table, notice that MSK pain has a spectrum of causes ranging from the benign to life-threatening conditions such as malignancy, infection, and trauma. Therefore, these must always be actively considered. These conditions, if not detected early and appropriately treated, may be associated with long-term morbidity and mortality. So the approach in management requires targeted history taking that, with the components discussed earlier by Dr. Leung, as well as a comprehensive examination, which includes the PGALs. And the third is appropriate knowledge of normal variants. Now, to narrow the differential diagnosis before we select lab tests to be done, a practical approach considers the differentials filtered by the age of the child, the pattern of joint involvement, as well as the chronicity of symptoms. So let me go through this quickly one by one. Thank you, Dr. Leung, for making my lecture easier, as you have already discussed some of it. So as in any presentation of any symptom, the history is of prime importance, with the precise nature of the presenting disorder to be clarified. So from the history alone, we will be able to elicit signs and symptoms that can help distinguish benign from serious joint pains in children. This division into benign and serious is only a guide, and no one feature can be considered in isolation. So we just have to remember that pain is never benign. It is the cause of the pain that may be benign. Okay. So in this table, pain that is worse after an activity and that felt at the end of the day, but is relieved by mild analgesics or massages, are relatively of benign etiology. In contrast to that of those that are serious, where pain is improved with activity and worse after rest, especially in the morning, as that seen in JIA, where they experience morning stiffness or gelling of the joints after periods of rest. I remember I have patients that they, after their classes, they complain of joint pains and they have difficulty getting up from their seats. That's because they already had gelling of the joints after being seated for quite some time. So moving on, symmetrical nocturnal pain relieved by simple analgesia and massage is a feature of growing pains, in contrast to that of malignancies, where the nocturnal pain is poorly responsive to analgesics and massage. Furthermore, systemic symptoms such as fever, rash, weight loss are found in more serious conditions. Okay, so now for the comprehensive examination, this one includes the PGALs as a basic musculoskeletal examination. Now, if you recall, in med school, PGALs is short for pediatric gait, arms, legs, and spine. It's a simple assessment to distinguish the abnormal from the normal joints in children. It has been validated in school-age children and was shown to have excellent sensitivity to detect abnormalities. It is simple and easy to do, as it incorporates simple maneuvers that we use in our clinics. It is quick to do, as I say, because it takes an average of about 2 minutes to complete. I wasn't able to download the video because the video that can be seen in YouTube is about 15 minutes long because of the explanations, but you can check on it anytime. So a copy me approach is useful to help engage children in performing the PGALs. So aside from those with MSK complaints, We do these maneuvers of Pigalle in the following situation. One is an unwell child with pyrexia. Second is a child with a limp. Third is delay or regression of motor milestones. Another is a child with chronic disease with known association with MSK presentations such as inflammatory bowel disease, psoriasis. Yeah. So the clumsy child in the absence of a neurological disease. Why? Because the child may be clumsy because of muscle weakness, probably secondary to JDM or juvenile dermatomyositis or other conditions. Okay, so we start by examining the back for posture, rash, and deformities, then followed by letting, okay. So we start by observing the child standing. So we examine his back for posture, rash, and deformities, followed by letting the patient walk normally. Then let the patient walk on his heels for a few steps, then walk on tiptoes for a few steps. This is to assess the gait as well as the joints of the foot. Those with affectation of the small joints of the feet will not be able to do this properly. Okay. So next, to examine the different joints of the arms. So aside from the small joints of the digits, manual dexterity and coordination is also assessed with these maneuvers. So we ask the patient to hold the hands out straight, make a fist, pinch the fingers and thumbs together, and touch the tips of the fingers. So mabilis lang talaga siya. Okay. And then part of it is to squeeze the metacarpophalangeal joints for tenderness. With the second image here, we are able to assess the joints of the fingers, the wrists, at the same time, the elbows, all at the same time. So we will be able to elicit any tenderness or limitation of movements in any of these areas. Okay. So the appearance and the different ranges of motion are evaluated from the wrists up to the shoulders. Okay. The third is for the next is the legs, where the knee and the hip joints as well as the muscles are evaluated. Okay. For the spine, we ask the patient to bend forward by So by forward flexion and lateral flexion, the cervical and thoracolumbar spine is assessed for any deviations or limitations in movement. The temporomandibular joint, or the TMJ, is also assessed by letting the child fit 3 fingers into his mouth. If he cannot fit the 3 fingers between the central incisors, then there is a problem in the TMJ area. It could be an early onset JIA that hasn't been detected. So any abnormal findings in any of the Pigalle's examination will warrant further examination of that area. Okay. So features that help to distinguish benign from serious joint pains in children. Again, this is only a guide. So benign conditions such as growing pains have completely normal physical exam findings. In benign hypermobility syndrome, aside from the hypermobile joints, all other P findings are normal. As compared to serious conditions where they may be swelling, there may be restrictions or contractures, there can be bony tenderness, muscle weakness, as well as muscle and subsequently growth abnormalities. Okay. So many children have minor developmental variants of the musculoskeletal system that will be obvious to us on examination. These were all discussed by Dr. Leong thoroughly. So it is very tempting for us to ascribe limb pain to these minor abnormalities such as flat feet, knock knees, bow legs, outgoing and intowing. But this should be resisted, okay, because they are all normal variants in growing children. Hence, these rarely cause significant limb pain. In most cases, the problem is a variation of normal development. which follows a benign and a predictable course. So Dr. Leong already discussed when will these variants resolve. Rarely does the problem persist into adolescence or require any treatment. So for the diagnosis, one of the diagnostic strategies used is what we call pattern recognition, where the history and PE are compared to previous patterns or cases, and the disease is recognized when the actual pattern fits. This is the refinement strategy commonly used in pediatric rheumatology and even dermatology. Okay, so aside from pattern recognition, the differentials will depend on, number one, the age of the child. Like it is uncommon to see rheumatic fever in a child less than 4 years old, and also rare for Kawasaki disease to be seen in a teenager. Okay, so also the pattern of involvement, we ask, are the joint pains additive? Are they migratory? Do they involve the large joints, the small joints? How many joints are involved? Is it a single joint or multiple joints? Okay. So for the chronicity of symptoms, we say arthritis, or the condition is acute if it's less than 6 weeks. Chronic if it's more than 6 weeks. So remember, an example is arthritis in RF, in rheumatic fever. Whether it's treated or not, it will resolve in a week or so. Whereas arthritis in JIA would persist for weeks or even months until it is adequately treated. Okay, so in dealing with MSK conditions, we at least do a CBC and an ESR, since infection and malignancy are the first to be considered or even ruled out. And then radiographic findings. So radiographs are only done for isolated, severe or refractory joint pains, such as knee pains that doesn't go away, okay, which may reveal the following results. Okay, so note that ANA and RF is not diagnostic of JIA or any other disease. Rheumatoid factor is usually negative in children with JIA. If positive, then it is actually used to prognosticate, since in the context of JIA, RF positive is associated with a more severe disease course. Okay. ANA, on the other hand, is often found in about 20% of normal healthy children and can even be present in high titers with transient illness. So both ANA and RF are not diagnostic. Okay. So there are several algorithms when it comes to diagnosing MSK conditions in children. Some use this strategy where the history and PE can distinguish between the inflammatory and the mechanical problems. Another is based on the age of the child. So from toddler years to the child to adolescence. Okay. Now others, I won't go through this one by one in the interest of time. Others use the character of the pain. So is it localized? Is it diffuse? And then they further check if the child is well or unwell. Okay, but otherwise, so when a patient comes to our clinic with a distraught parent who gives us all this history of aches and pains and whatnots, all these differentials really come into mind. But what is important is we know what is normal, what to look for, and when to worry. And these are, if there are persistent changes that fail to resolve by the expected age, if there are progressive changes or worsening, if there's a lack of symmetry, there's already associated pain or functional disability, systemic upset, and dysmorphic features or short stature that will make us consider a genetic condition. Okay. So red flags in MSK conditions refer to features that may suggest serious life-threatening diseases such as malignancy, septic arthritis, osteomyelitis, or even non-accidental injury. So in the context of a single swollen joint, the infection and malignancy must always be considered. In the context of multiple swollen joints, we consider inflammatory, reactive, or multi-system diseases. These red flags, so fever or systemic upset and organomegaly, are consistent with malignancy, infection, and also other inflammatory diseases. that would warrant further evaluation. So acute joint pain that is often severe and localized can be a feature of infection, especially if it involves a single joint. Okay? Now, swollen joints in children may be subtle or difficult to appreciate on examination, especially if the changes are symmetrical. And in young children where the history is, where the history can be vague. Next is bone pain, which is often described as deep and throbbing in nature, usually located in the long bones rather than in the joints. So when we see this, one of the things that we should consider is malignancy. Okay. Night pains that are not responsive to simple analgesia, as mentioned earlier, and persistent as opposed to intermittent joint pain is more worrying. So in instances where there's incongruence in history, presentation, and P findings, always consider the possibility of abuse or non-accidental injury. Now for my last slide. MSK complaints in children are common. They are often benign and self-limiting, but can be presenting features of significant, severe, and potentially life-threatening conditions. Children take a longer time to develop manifestations of diseases like connective tissue diseases. Hence, repeated exams will be necessary. And persistent joint pain may require long-term monitoring for a proper diagnosis. Now, diagnosis rests on competent clinical skills, knowledge of normal variants, as was discussed earlier, red flags to suggest severe conditions, and the judicious use and interpretation of investigations. So thank you for your kind attention, and these are my references.